depression. So his research also includes the genetic causes of suicidal behavior and treatment response to psychotropic drugs. Finally, Dr. Souery is the coordinator of an international group of experts on treatment-resistant depression. He is the member of the task force on the use of psychotropic drugs at the Belgian Ministry of Health, so le Conseil Supérieur de Santé. He acts as a scientific collaborator in the laboratory of medical psychology, archaeology, toxicology at Université Libre de Bruxelles. And he is also the secretary of European Accreditation Committee in CNS. And Dr. Souery, finally, we'll let more people in. He is now running as a multidisciplinary psychiatrist at a center and a practice based in Brussels called Psy Pluriel. So, if you don't mind, Dr. Daniel Souery.
Thank you, Mylis, for this very nice introduction. I'm very pleased to be here as an invited speaker. As it has been said, I was participating in previous events in Brussels. And I must say I'm used to the classical type of congresses and international meetings like the ones that are organized by scientific societies and being here in this kind of event, for me it's a real challenge, but it's a real pleasure to share my practice with people from different horizons. So today I will focus on transdiagnostic approach in psychiatry and related disorders. How did I came to this topic? Basically, it's from my clinical experience and from the patients. I was trained in a university setting. I made part of my career as a teacher in a university hospital, in psychiatry, the temple of psychopharmacology, of diagnosis in psychiatry. And then I moved 10 years ago and I created, together with some colleagues, an outpatient clinic in Brussels. And then I realized that all that I learned so far and up to now are mainly from the last 10 years, let's say. And this is really based on sharing experience with patients and their families. And this has, lead me to be much more involved in this kind of concepts. And I will share this today with you. So this may be important for some of you. I receive a research grant from some foundations, but also we are running some clinical research in the framework of grants from some pharmaceutical companies. But I think that my presentation today is not at all linked to this potential conflict of interest. So what I suggest is to go through these items. I will introduce my lecture by going through the unmet needs and the frustrations and limitations that we are facing in psychiatry when trying to make diagnose, when we are using the classical diagnostic logic, that it's very difficult then to really understand what's the meaning of the symptoms that the patients are presenting to us. And it's very difficult with this simple diagnostic logic also to find the best therapeutic approach, whether it is a psychological approach or psychopharmacological approach. And by doing that, I will also go into more details into mind and brain in the way we approach mental disorders. And then I will go really into the subject by giving you a taste of recent ongoing research. This is ongoing research. It's not yet something which is very well established, but the last few years there is a lot of publications in what is now called transdiagnostic approach in psychiatry. So meaning that going from the level of syndrome or symptoms approach to something which is much more the core phenomenon of psychiatric disturbances. And then I will try to make the link between these psychiatric symptoms and emotions, because during my presentation I will have a kind of obsession, and the major theme will be emotions. Throughout the presentation I will this is it's not on purpose, but when I prepare this presentation, when I work, because I worked on this topic for the last few months or years, always and again I find publications, works, scientific research on emotions. So it seems that this is the really core phenomenon of most of the psychiatric symptomatology. And I will give you an example of how this can be used at the clinical level by saying something on emotions and bipolar disorders, and then my concluding remarks. So if this is okay for you, let me introduce. So I don't know if you are psychologist, psychiatrist, or from other professional background, but anyway, we all know that as clinicians, it's very difficult to come to a diagnosis in psychiatry. And in modern psychiatry, we are very frustrated because the only thing that we have is a kind of vision where there are diagnostic categories. Most of the international diagnostic systems, they do offer this categorical approach into psychiatric disorders. And most of them also propose that all these categories like schizophrenia, depression, bipolar disorder, post-traumatic stress disorder, all of the anxiety disorder, ADHD, all of these diagnostic categories would have a distinct etiology and, of course, different clinical presentations. But in real life practice, we all see that this is totally different. Many patients will show clear signs of general psychopathology, very severe psychopathology, but will not fit precisely within these proposed categories. And the boundaries are not clear. And this is one of the arguments saying that we should look for another type of approach in diagnosing psychiatric disorder. Another argument would be the comorbidity. We all know that most of our patients, although we have a primary diagnostic like depression or bipolar disorder, most of them will have something else beside the primary diagnosis. So this means that this single patient will have like 4, 5, or even 10 different diagnoses? That's for me almost impossible. So the coexistence between a spectrum of symptoms within a primary diagnosis occurring with other kind of symptoms is an argument saying that this is not the right way to approach the psychiatric diagnosis. Another argument, which is not mentioned here in the slide, is the pharmacological treatments. We know that most of the antidepressants are used for depression, but also for anxiety disorders. Atypical antipsychotics are used primarily for psychosis and schizophrenia, but some of them have also mood stabilizing properties. Some of them, like quetiapine, for example, has also an indication to treat depression. So it means that, okay, if all these medication works on different type of symptoms, it means that there is something common there that we are missing, and that would be a great, also an important argument towards another type of diagnosis. Even the champion of categories in psychiatry, the DSM, you know, the Diagnostic and Statistical Manual, which is now the 5th version, coming mainly from the US, but used internationally. Even the champion of diagnostic categories is challenging the notion of diagnostic categories. This is one of the introductory remarks that you will find also in previous versions of the DSM, that there is no assumption that each category of mental disorder is a completely discrete entity with absolute boundaries dividing it from other mental disorders. So in the absence of, the problem is that we don't have any, let's say, pathological marker in psychiatry, so the current definitions are based on syndromal approach. It means that when I see a patient, he will describe his symptomatology or clinical presentation in terms of signs, symptoms, like anhedonia, suicidal ideation, agitation, for example, or cognitive disturbances. And these kind of signs and symptoms, together with the outcome of the problem, let's say, not the diagnosis, but the problem, and some of the familial aggregation patterns will help me to delineate what we are calling diagnose, for example, depression, bipolar disorder, or ADHD. The problem is that many of these symptoms are, from the mental disorder, let's say, are on a continuum with normality. And the best example is dysphoric mood, for example. We all have dysphoric moods from time to time based on what's happening in our life. But it's not only for depression, also for cognitive problems, but also for psychosis. Okay, you may have delusional features or symptoms, but when I am very anxious, I can develop some kind of thought that will resemble like psychotic features. So this is not, I think I'm not schizophrenic or paranoid or whatever, but I may have some paranoid thoughts from time to time based on what's happening in my life. Also, what is difficult is what can help us in differentiating normal versus pathological phenomenon. And here again, it's very frustrating in psychiatry. What we have to do that, what is proposed, is the duration of the phenomenology, the duration of symptoms, and also the severity of the symptoms. But here again, it's very arbitrary, because, for example, concentration and attention problems that will interfere significantly with school performance then will lead to a diagnosis of ADHD, for example. But it's very subjective, depending on the person, the way the person will adapt to the situation, but also the way the environment will adapt to the behavior of the person. So if at school the teacher and the staff is able to cope with this kind of situation, there won't be any diagnosis. And so that's very problematic. And so these boundaries may be convenient and may permit somehow reliable delineation of syndromes in psychiatry, but no doubt there is no inherent biological meaning for these categories, and they are very much imprecise. So this has led to a lot of thinking, not only in psychiatry, but in psychology, even in philosophy, trying to approach mental disorders. And so this is not new. This is a publication, a very important publication in 1997 from Nancy Andreasen. She's a psychiatrist from the US. And she was pioneered in proposing a research framework in order to better understand mental disorders that are basically disorders that are expressed through mental processes or mind disturbances. So it's difficult to make the link between these symptoms and something in the body which is disturbed. And so many years ago, together with many researchers around the world, and also thanks to the some of the neuroscience technologies like brain imaging, but also genetics, there was a lot of research trying to make the link between mind's problems and body, which is the brain. But this, even before Nancy Andreasen and the 90s, like, for example, Sigmund Freud I mean, he was a neurologist. He was convinced from the early stages of his work that the psychic problems had a neurologic substrate. Although he abandoned this kind of work, he was very much convinced about that. So this has led to a lot of research, and let me give you some examples, and you will see this is not totally different from what I will tell you later about the transdiagnostic approach. So, for example, and this is also studies from our research from the 90s, looking at the relation between psychic symptoms and the body, meaning the brain. And so this has led to, thanks to brain imaging studies, to insight into what is the neural substrate and neural mechanism of psychiatric disorders, exploring the neuroanatomy mainly of emotions. Again, I told you this will be my obsession during this presentation, because most of this work, although that was not the primary objective, they really find something in the emotional mechanism leading to psychiatric symptomatology. For example, the exposure to an adversive experience will lay down a powerful memory trace somewhere in the brain that is difficult to extinguish. Most of you may work in this field and recognize this kind of issue from the patients and the experience that we have from the patients. And this kind of memory trace, it has been possible to show where it is exactly located, let's say, in the brain. And I will come later. I don't know if you are familiar with brain regions, but I will illustrate that in a moment. But there is one structure in the limbic system. You know, the limbic system is the headquarter in the brain of the emotions. This is the instinctive brain, let's say, the lower part of the brain. There is the amygdala, in which we really store the emotional trace of the experience we have lived. And this structure, together with other structure, I will come to that later, will play an important role on how this emotional trace will then resurface, let's say, and cause many of the symptoms in psychiatric disorders. Not only in psychiatric disorders, but I will say in psychological suffering, not only pathological suffering, let's say. And it has been identified, well known, that this mechanism will imply different, processes. One is the fast track reaction. So this is really instinctive, like it involves, as I said, the amygdala, part of the subcortical regions, the limbic systems, including some regions will help to as I said, to write the emotional trace of the event, and this will lead to very rapid and crude response. This is really like animals, let's say, because that's what we are, by the way. So we are reacting first with the emotional reaction, and then there is a more complex mechanism which will lead to the implication of other regions of the brain, more complex regions, the ones that are, based on our education, our knowledge, our way to behave, let's say, what we learned, and will involve, the prefrontal cortex, which is the headquarter of the rational. It's the opposite from the emotion. And then will lead to an appropriate, let's say, reaction. But if one of these regions is disturbed, or the communication between these regions is problematic, then the reaction will be not balanced, let's say, and may lead to psychological pain, but also to symptoms leading to psychiatric problems. Not only we know much today about these regions and how they work, but we also know which neurotransmitters are involved in this mechanism. So this is the kind of research. So here you have an illustration of the brain. Here you have the limbic systems, with the amygdala, and this is the first region that will be mobilized when you are stimulated by something which will create an emotion, which can be fear, sadness, anger, for example. And this is the fast track mechanism. You will react, you have the emotion, the body will feel also something because of this emotion, and then there will be a connection from these lower brain regions to upper brain regions in the cortex, leading to thinking about what's happening to me. So the emotion will create a thought, and I will think of what's happening to me, and the balance between these two will lead to an adequate behavior. But we know that in some psychiatric conditions, like depression, for example, but not only depression, but also addiction, anxiety disorders, the amygdala will not react the same way as in normal behavior. In many psychiatric disorders, you will have an hyperactivity of the amygdala. In some psychiatric disorders, it has been shown that the amygdala is very much, reacting to any kind of stimulation. And not only that, but if you are, for example, a depressive patient in remission, okay, you will have very sensitive emotional reactions, very high emotional reactions, but your cortex, your frontal cortex will react appropriately and try to accommodate with this very important emotional reaction, and the cortex will tell the limbic system, okay, calm down, this is just something happening to you, it will not be like this the rest of your life, so the emotion will be let's say, calmed. But in depressive patients who are symptomatic, then you have also the problem of the cortical region. The reasoning is also problematic. So it will create negative thought. But based on the emotion first, if you are a symptomatic depressive patient, you will develop all these negative thoughts that are associated to depression. And this has come to, you may be familiar to the bottom-up, top-down mechanism in the brain, where first you have from the bottom line the activation of the subcortical regions within the limbic system, leading to the emotional reaction, and the body will also feel something. Before you know why you are angry, your body will feel something and you will see something from the body. So these are really primary processes, the fast track activation, but from the bottom you will activate the top regions, the regions from the top, the cortical regions, and there is also a regulation going from the top to down, so the bottom up, top down regulations. Sorry. And all these mechanisms are very well known. And here I'm not talking about psychiatric disorders like depression, OCD, anxiety disorder, addiction, but it is strange, but this has been described in most of the scientific work and the brain imaging work in all these kind of disorders, and this is not limited to these disorders, but many others. It's like, researchers in depression, they don't talk to researchers in anxiety disorder or addiction, but they found mostly the same kind of findings. And because they look first at the diagnostic categories and trying to see what's going on in the brain. But what we need to do now, it's really the opposite. It's looking at the brain first and the basic mechanism by which the psychopathology, let's say, is produced, whether it is anxiety, depression, cognitive problems, doesn't have much importance first, but first looking at what's going on in the brain when it produced, let's say, psychopathology, and then look if it fits with the diagnostic categories. And the key message from this presentation is that when you do that, you see that these basic mechanisms are fitting with all these type of diagnostic categories. And this is the type of research that it's ongoing for the last, let's say, decade or even less, trying to see what are the transdiagnostic neural substrate or mechanism that maybe explain all this kind of complex phenomenology from all these psychiatric categories. And this is very important because it will really change the way we approach psychiatric disorders, but it will also change dramatically the way we treat psychiatric disorders, because then we are not going to treat psychiatric disorders, but we are going to treat psychopathology, signs, symptoms, things that are problematic, cognitive, for example, impairment, and things like that. And so the objective then is really to find markers or signature of psychopathology rather than diagnostic categories. And there has been research looking at, altogether depression, bipolar disorder, substance abuse disorder, OCD, PTSD, anxiety disorder, schizophrenia. And believe me or not, when you look at all these scientific literature, again, researchers are different from different institutes, different places around the world, not talking to each other, but finding more or less the same core mechanism leading to psychopathology, whether it is anxiety, depression, psychosis, cognitive dysfunction, or anything else. And this could be also a marker of familial vulnerability, because you find in some families, for example, people with depression and some other parents with bipolar disorder, and then you find a schizophrenic uncle, or and what is then the common patterns leading to this kind of psychopathology. And this is the kind of research, I will not go into much detail, but for example, in this study, they looked at hundreds of studies among the different diagnoses like schizophrenia, bipolar disorder, unipolar depression, OCD, obsessive compulsive disorder, substance use disorder, anxiety disorders, and trying to see whether all these findings from all these studies for the last, 20 or 30 years, they found something which is in common. And the result is clear, is that, and this is structural brain imaging, it's just a picture of the brain, it's not functioning of the brain. I will come to functioning a little bit later. And if you just look at the structure of the brain, which regions are involved in all these different categories of psychiatric disorder, you find indeed some regions that are very much involved, again, in the processes of emotions, in the regulation of emotions, like, for example, the interior singular cortex. I will come to that a little bit later, which is a key region, because this is the region by which the emotional brain will communicate with the rational brain. So if you miss this communication, then you really have, problems. Not only if you are a psychiatric patient, but as a person. And there may be situations in your life when you will miss this communication. If I am now panicking, I will have, fear at a certain level that I will lose my communication with my rational brain, and you will see symptoms, really, and you would like to treat me with a benzodiazepine or whatever. Okay? And again and again, when looking at these different studies and different research, you always find something related to emotional perturbations, and some of the regions that are very much involved in the process of emotions. So is this means that the phenotypic difference that we see, bipolar, different from depression, from schizophrenia, from OCD, from ADHD, are these phenotypic differences negligible? No, doesn't mean that. It means that this model will emphasize the importance of shared endophenotypes across the different psychopathology, but this will not exclude that there may be some difference. And today we don't know where it comes from. Of course, you can have different etiologies, even though the regions involved are the same, and the same mechanism will lead to symptoms. But the etiology, the cause of this problem may be genetic, for example, may be environmental, for example, may be acquired during life. So the same disturbances in the mechanism and the functioning of the brain can be the consequence of different etiologies. So it doesn't mean that we exclude different etiologies, but we do not exclude also different presentation or clinical presentation or phenomenology, because although the same mechanisms are involved, the environment can nuance or modulate the way it is expressed. If I am taking drugs, for example, the same brain mechanism leading to, I don't know, anxiety or impulsivity will not be expressed the same way if I don't drink alcohol, for example. But also many other things like the family environment, if I am a loved person or not, if I am happy or not, in peace with myself or not, this will lead to different type of expression. Okay, so it's not excluding different etiologies, and it's not excluding different phenomenologies. So I was telling you about structural brain imaging, where indeed all this kind of research, they found specific regions of the brain that are involved in the psychopathology, in the core, mechanism of psychopathology, and mainly the regions involved in the emotional processes. But not only the regions have been found to be of interest, but also the connections between the regions. And this is a field of research which I think will lead to major findings, not only in psychiatry, by the way. But so there are now some research with brain functional imaging looking at how all these regions communicate between them. And this will, because you may have a normal amygdala, which is reacting appropriately to any kind of emotional stimulation. But if the connection between your amygdala and your frontal cortex is not adequate, then you may have some psychological pain or psychiatric problems. So, again, then what's the common denominator of all these, psychiatric disorders? And as I said, again, one thing that you will see, it's not the only one, but really it's the major one, is the emotions. So really it seems that by understanding the emotional processes, we will understand the link between psychiatric symptoms and what's going on in the brain. So we will understand what is really the neurological substrate. I'm not telling you that all the psychopathology, it's only related to the brain and to neurological problems. It is, of course, very much influenced by your personality, your environment, your education, and many things like that. But anyway, you must have your brain activated to produce, let's say, the symptomatology somehow. It's not the cause, but it's the substrate by which the symptoms will be expressed. So we will understand most of the psychiatric problems by understanding the neurological substrate of the emotions and the behaviors that are associated to emotions, by the way, the symptoms. And most of these research found that The major problem is somehow emotional instability, whether it is for bipolar disorder, depression, anxiety disorder, addiction, OCD, and ADHD also with impulsivity. So the core phenomenon is emotional instability or emotional hyperreactivity. And this with as the neurological substrate the cortico-limbic structures and communication between the different structures. Let me just spend some time on emotions and feelings. Here again, it's like we are not discovering anything, by the way, because I will tell you later, I mean, Spinoza, the philosopher, came to the conclusion that's the key point in human suffering in general. So today we are trying to link that to psychopathology among all the psychiatric disorders. So an emotion is a brief affective reaction that our organism, our brain mainly, produce in response to internal or external event. And this is common to the whole animal kingdom. It will lead to a behavioral expression. It's reactive, it's dynamic. It's the emotion that will lead me to do something. It's very important. If I'm lacking my emotions, I cannot do anything in my life. So it's linked to what will help me to be in movement, to be dynamic. So it can be joy, enthusiasm, but also sadness, anger, rage, jealousy, fear, anguish. And this is different than feelings. Feelings are more stable affective attitudes. So it's like first you have the emotions. It's the fast track mechanism, and then you develop something else which is more elaborated, which may be a feeling, a more stable affective attitude, which is subjective and depending not only on the emotions but also on the surrounding, the environment, your education, how you deal with your emotions. I told you about Spinoza, so you cannot say something about emotion and ignoring Spinoza. So many centuries ago, he said something that we know today and very simple, that the motivation, the emotion, the feelings, and he called that the affects, and he considered that that was a central aspect of humanity. Not only psychiatric problems, but humanity. Joy and sorrow were two prominent concepts in his attempt to comprehend human beings and suggest ways in which their lives could be lived better. So it means that it will certainly produce a lot of psychological pain, psychological suffering, and certainly psychiatric symptoms. More recently, if I may say so, Antonio Damasio, the neuroscientist, let me quote it, explaining the biology of feelings and their closely related emotions is likely to contribute to the effective treatment of some major causes of human suffering, among them depression, pain, and drug addiction. So going from human suffering to psychiatric disorders. So it's kind of continuum explained by the same core mechanism and the same core neurological substrate. I think I will skip some slides because time is running. So, going to the end of my presentation, I would like to explain all that has been said through an example of psychiatric disorder, which is bipolar disorder. So you know bipolar disorder, it's characterized by mood swings exceeding in intensity or duration the normal mood swings that we may all have. So I'm always saying to my patients, we are all bipolars, but depending on the intensity of the bipolarity of my mood fluctuations, I will develop symptoms or not. And So the testimonials of the patients are clear. I mean, they are telling us what Spinoza was telling us many centuries ago. They are all talking about their emotions. My emotional tsunami, my mental epilepsy, my emotional fires, emotional lifts. So this is telling us that we have to look bipolar disorder, not only, I'm sorry, part of the slides are in French, but we are not, in order to really understand what's going on in bipolar disorder, we don't have to focus only on, the diagnostic criteria, which is having a depressive episode or a manic or a hypomanic episode, but we have to look more carefully on what's going on between the episodes, upstream of the episode, in the normal phase of the disorder. And what we find there is, again, related to emotions. This is the kind of study looking at prodromes of bipolar disorder, not only in patients when they are very young and they still don't have their real diagnosis, but also offsprings of bipolar patients. And what you find here is something which is related to emotion, like prodromes of bipolar disorder. It's irritability, anger, instability, and mood swings. And this is how very, very reliable. And I I see a lot of patients saying, I come to you because I have a problem from the first day of my life. I don't know what it is, but I have a problem. As a kid, I was crying a lot, and I have a lot of emotional outbursts, and this can start very, very young. So, better understanding in a better way what is bipolar disorder, and to treat in a better way what is bipolar disorder. It's not only focusing on the mania and depressive episode, but really focusing on the person, how the person is functioning in the normal phase. And in the normal phase, all the patients will tell you, even though I'm not manic, I'm not depressed, I am very much emotionally reactive or unstable. I have a lot of emotional sensations, and my behavior is very much influenced by my emotions. They do recognize their problems more when you are talking about emotions than if you are talking about only depression and mania. And it's not by chance that the treatments that we are using in bipolar disorder, like lithium, for example, but also the other mood stabilizers, like the anticonvulsants, all of them, what they do is they decrease the neuronal reactivity by acting on these, ions channels and some of the neurotransmitters. The GABA, it's an inhibitory neurotransmitters. Thanks to the GABA, I have my reactions that can be, tapered in order to reach the right balance in the brain for any kind of reactions, not only for the emotional reactions. So I think that if we are using lithium only to treat mania or to treat depression, the objective of the treatment will not be appropriate. And also the understanding of the patients will not be adequate. But if we also try to apply these treatments in order to target the emotional instability, maybe we will find that we will need other type of treatment strategy, not only the medication, but also psychotherapy, meditation, relaxation, and maybe natural treatments that may help in the normal phase of the mood, let's say, instability. So we need really to revise the way we treat these kind of problems, and also to explain that to the patient. So here again in the brain, you see the limbic systems with the structure of the lower brain, the reptilian brain, the instinctive brain, with the amygdala, which will be mobilized when there is a stimulation leading to an emotion, mainly anger and fear. But you see that this fast track process will lead to an activation of my frontal cortex, the one it is rational, educated, who learned a lot of abilities, and the communication between these two will help me to have an adequate behavior. But if this is not the case, then it can lead to symptoms. Okay, so this is very important on how these two communicating. And let me go a little bit faster because I would like to have also some time for the discussion. This is a very important study. First, they were not looking at transdiagnostic approach, but in the study they were comparing bipolar offsprings from bipolar patients to offsprings from many other psychiatric disorders, including panic disorder, alcohol abuse, phobias, GAD, major depression. So they are looking at offsprings of these patients. And at first, this is functional imaging. You see that when, so the experimental paradigm was to stimulate emotional reactions, like, the emotional, they were using faces, anger, sadness, and then your brain is reacting in terms of fear, anger, or sadness. So first you see the amygdala stimulation, so the lower brain is reacting, and you see that the bipolar offspring are very much reacting compared to healthy control. But you see also that the non-bipolar offspring, the offspring from, anxious patients, alcoholic, OCD patients, they do also overreact, although this was not the objective of the study. But you see that the amygdala of all the offsprings of the patients, regardless of the diagnosis, was overreacting. And then you have the second phase, which is the activation of the communication path. The highway leading from the limbic system to the cortical region. This is the anterior singular cortex that you saw previously. And here you see that the bipolar offspring, they did not activate the pathway. So it's like it was blocked. And also, but in a lesser extent, the offspring of the other patient. So you see here that it's going in the same direction, but not the same intensity. So this may be an explanation of the different type of symptomatology which is produced. And by the way, this was completely different from the healthy controls. And you see here the last phase, which is the activation of the frontal cortex. And this is more complex because you see that bipolar patient, they will activate their frontal cortex depending of the kind of emotion. Whether it is joy or fear, it will be in an opposite direction. And you see that also for the offspring of other type of patients. So again, this is very preliminary results. You cannot conclude everything from that, but you can see how the brain is functioning and how, among different psychiatric disorders, you see the same patterns. And you can really do a brain mapping based on the structures that will be over or subactivated within the different, let's say, diagnostic categories. And conclusion from that is that it is widely accepted that the origin of bipolar disorder, but I may say psychiatric disorders in general, I can copy-paste the conclusion of this paper from bipolar to anxiety disorder, to drug addiction or whatever. It's really related to the functional connectivity between these two dimensions of myself, which is my limbic system and my emotional brain, to my cortex and rational brain. And this is another evidence. I can copy-paste this sentence, which has been written by a professor in psychiatry, mainly involved in addiction and alcohol disorders. Individuals with bipolar disorder or anxiety disorder suffer in the extreme with two basic aspects of human nature. They cannot control their emotions and they cannot control their behavior. So you see, this is exactly what I would like to say, and this is the key message of the presentation, is that we should try to forget about the diagnostic categories, which, by the way, makes sense, as I told you. I mean, I think it makes sense because the basic mechanism of psychopathology could be the same for all these diagnostic categories, but it's not expressed the same way. And the way it is expressed may indeed make sense when you try to make a diagnosis. And what I found in the literature is that most of the findings are focusing, are obsessed, let's say, although it is independent, on all these brain regions related to the emotional processing, basically the limbic regions, the cortical regions, but most of them also on the communication between these two dimensions. And this is where I think the future will be different in trying to make diagnose in psychiatry, but also to treat psychiatric disorders, because this, I think at the clinical level, it's something that we realize and that we know and that we are applying. Regardless of the diagnosis, we are really focusing on psychopathology. We're trying to help the patients and the people suffering of psychiatric, problems and symptoms by understanding how the psychopathology is produced within their mental, apparatus or disposition, rather than trying to help them by just telling, okay, you are bipolar, you are OCD, this is the way I will treat your symptoms. Thank you for your attention, and hope you will have some remarks. So we still have time for some comments or questions, yes?
Yeah, you mentioned Kantian. So I just
Sorry?
You mentioned Kantian in your presentation. The psychiatrist, the self-medication hypothesis? Kantian.
Edward Kantian.
Yes, sorry.
So, with his hypothesis that, if you're depressive, you might use alcohol, if you're hypertensive, you might use cocaine, something like that. And what you're saying then, basically, my understanding of it is that the brain's almost like that as well, in that the underlying thing might be one thing, but the way in which the brain deals with it, it could be anxiety or OCD or whatever. So is that correct?
Absolutely,
okay.
This is correct.
Then I've got a second question, which is, in psychiatry you talk about dealing with the symptoms, but isn't it a case that actually there's a whole portion of work to do around emotional regulation and the way that we teach parents to, help their children emotionally regulate? I mean, wouldn't that help an awful lot of this? And from an environmental point of view, if you've got addictive parents, then they're not equipped to do that.
Yeah, indeed, and thank you for this comment, because this was not part of my conclusion, but this is the real conclusion. So the way we will treat all these psychiatric conditions will depend on the way we will help the person in trying to regulate his emotions and the emotional reactions. This is what I'm trying to do in my clinical practice. It's difficult nowadays because the patients are coming, with they need strongly the diagnosis, they need to have the checklist of their symptoms and things like that, and you need to have a treatment which is recognized for these symptoms. But we must say, I'm treating resistant patients, and part of the resistance is that by doing that we are not targeting the right mechanism. And you are right. By looking at the emotional the way we deal with the emotion will certainly help. And then you will realize that although the treatment may help, the pharmacological treatment may help, like alcohol may help, like cannabis may help also, for the symptoms, for the intensity of the symptoms, you are not looking at the core phenomenon. And the core phenomenon will certainly need some other type of approach. I don't know, meditation, TC.
Don't you think that the client's need for diagnosis is based on the setup from a psychiatric background in which, psychiatry is all been based on the DSM?
Yeah, but we have to change that, and it's really difficult when I say to my patient, okay, I make a diagnosis. My diagnosis is that you are it's very difficult for you to deal with your emotions, and you have emotional hyperreactivity. This is my diagnosis. They don't believe it because it's not bipolar, schizophrenia, anxiety. It's very difficult to change the paradigm. It's a challenge.
And then, sorry, if you give that latter diagnosis that you're hyperreactive, you're saying by virtue that they've got a personality disorder with its own negative connotations.
Indeed.
It's not very beneficial.
On the clinical level, if you talk about a continuum, then I mean, there's two things. You need to find a threshold for pathology. In other words, trying to find normal, and then finding that threshold. And when do you medicate? When do you not medicate? And that becomes, on the clinical level, that becomes a real challenge.
Indeed, thank you. This is not solved by this kind of findings. There you may better understand by which mechanism the symptoms are produced, but still you have the challenge of putting the threshold, and this very much depends from one person to the other. But I don't know what will be the solution for that, really.
Thank you very much for your lecture. We work at the Küsner practice in Zurich very much psychotherapeutically with somatic experiencing that exactly works with the nucleus accumbens, with this limbic system, and does not really go top down. Do you have experience with that approach, psychotherapeutic approach?
I don't have specific experience, but first I would like to say that 99% of my patients, they do also have psychotherapy in parallel. I'm not psychotherapist. So I do strongly believe that psychotherapy is part of the solution, no doubt. What kind of psychotherapy? That I'm not a specialist, but I'm trying to do somehow personalized approach, and for each type of problems with the patients, I will orient with one or other psychotherapy. But even having said that, I think that there is no single therapy which is adequate for a single problem. Patients may have, 2 years of TCC psychotherapy, then psychoanalysis, then other type of therapies, everything which can help in dealing with, these problems.
Thank you for a fascinating talk, where you've spoken about the neurobiology and the neuroanatomy of emotions and feelings and so on. But a question that always fascinated me, or concerned me, and I'm interested in your opinion, is can these conditions occur in anybody, or does there need, this is the core issue really, or does there need to be a pre-existing vulnerability? In other words, can anybody get it as a function of circumstances of their life, and traumas and whatever, or specifically with addiction, which interests me, or does there need to be a specific vulnerability that predisposes to the condition?
Very good point, thank you. No, I think that we are not the same, and we don't have the same chance, let's say, in our life. So there must be a vulnerability, but then it's also a complex question, because the vulnerability can be genetic. You will find families from one generation to the other, 5 or 6 generations, when anger is overexpressed. There is no diagnosis, it's not bipolar, it's not whatever, but the grandfather was very angry, always behaving. So there may be some genetic vulnerability. You may inherit a package of genes that will lead your limbic system to overreact. This is scientifically, it makes sense. But the environment will also play a very important role, because although you may have this genetic vulnerability or not, you can gain it from your education, from your environment, from your trauma, and this is where we are not the same, because...
is there any evidence?
Sorry?
Is there any evidence? I mean, I understand what you're saying, but is there any hard evidence?
Oh, sorry, yes, of course there is evidence. There is evidence that early trauma in your life will make your amygdala being stronger, and that you don't do anything trying to be helped in this regard. It's like bodybuilding your amygdala. at each time you make, an anxiety or panic attacks, you are reinforcing. So there are strong scientific evidence that indeed there is a vulnerability for that, and that you can modulate the vulnerability. This is the brain plasticity. If you are stressed, if you take drugs, it will be even stronger. But if you help yourself, you are happy, you have good relationships, then it will be modulated in the other way.
And you give it to the
Sorry,
next
one by
generation.
one, sorry.
Okay, maybe the last remark.
Most people suffer trauma at one stage or another in their life, but very few become addicts.
There may be some protective factors also. I didn't mention that. But again, this is very much complex, and it's for next year maybe. Thank you for your participation.